Okay, so I suppose that means that people are already able to listen now. Welcome to those who are logged in. Welcome to this EFIC webinar on the topic of the wide spectrum of clinical CRPS presentations. My name is Andreas Gobel. I'm the chair of the EFIC task force of CRPS, and we've got a fantastic program today with fantastic speakers. We'll start off with Professor Janne Gerd-Mühlen, who is the current chair of the CRPS SIG for the ISP, and who will give an overview over the clinical diagnosis of CRPS. And we will take questions straight after this. So every talk will, so Janne's talk will be probably about 10 minutes, I think, and then we'll have up to 5 minutes of questions. This will be followed by Dr. Selina Johnson, who was part of the team who's developed the EFIC supported CRPS web app mostly for clinicians throughout Europe. And again, we take questions after this. And then this will be followed then by 3 presentations on CRPS phenotypes that we've seen. They are case presentations, really, by Janne, myself, and Professor Heike Rittner, who is a professor of pain medicine in Würzburg, Germany, and a chair-elect of the CRPS SIG. Of course, the occasion is, and EFIC has asked us to do this rightly in this month. It's also recognized as CRPS Awareness Month. And as we know, CRPS is a rare condition, but it has a high burden for patients. And even if we have just one episode of CRPS and get better afterwards, the likelihood is still that we have to change our job, maybe through life. So that about a third of people cannot go through the same job, even so they don't have that intrusive everyday pain anymore. And then there's about 15% of all patients who have CRPS who will not get better at all. And we really clearly need better solutions to treat this condition. So without any further delay, I would then like to hand over to Professor Janne Gerd-Mühlen for her talk on the diagnosis of CRPS. Thank you, Janne.
Yes, thank you very much. I hope you can now see my screen. I will give a short introduction about the diagnosis of CRPS and refer to the Valencia consensus on the Budapest criteria. As you all might know, CRPS has been or had been listed upon the ICD-10 under the primary autonomic disorders, which has now been changed so that CRPS is now listed as a primary pain disease, which we all think is.
Janne, you don't have the full screen on. Can you click on full screen on your lower right corner of your own screen? Is that possible for you?
Like this, maybe.
Yeah, excellent. Thank you.
Do you see it now? Okay, great. Yeah. Okay. So now CRPS is listed under primary pain disorders, and I think as we all are pain specialists, we think that is the right or appropriate listing. So when you refer to CRPS, I will give you a short model that, of course, doesn't include all the different pathophysiological mechanisms, but can give a few ideas about the most important mechanisms. So if we have a trauma, for example, a radial fracture, we will have, of course, upon healing, a release of inflammatory cytokines, mediators that will lead to inflammation and inflammatory symptoms, such as, for example, redness and edema. TNF-alpha will also be released and lead to trophic disturbances. The cytokines and TNF-alpha themselves also work on peripheral nerve fibers and lead to peripheral sensitization, including pain and hyperalgesia. Due to the sensitization of peripheral nerves, they also release substance P and CGRP that further enhances the inflammatory reaction that can be observed in CRPS. It also leads to microvascular disturbances due to edema with high intra-tissue pressure. Due to peripheral sensitization, there's also central sensitization with maladaptive neuroplasticity that might in part explain the body scheme disturbances that we observe, as well as central motor symptoms. We also have an upper regulation of alpha-2 receptors that might lead to sympathetically maintained pain. There are also autoantibodies partly involved, but I have not included them in this pathogenetic model. We have psychological issues that can also, by the release of catecholamines, work on the upregulated alpha-2 receptors and lead to vasoconstriction. And as you know, vasoconstriction leads to ischemia, and ischemia can also lead to pain. So the Valencia consensus criteria that I would like to introduce or repeat upon this talk is not an improvement of or not a change to the so far used Budapest criteria for the diagnosis of CRPS themselves, but it is an improvement of the introductions and explanations for the Budapest criteria. The Budapest criteria include the presence of sensory, motor, and autonomic symptoms and signs. Symptoms are what the patient itself observes, and signs is what the doctor observes upon examination. They have been published first in 2010. And we know that the specificity is significantly better than the old JASP criteria. I will show you the specificity and sensitivity later on. So what do they include? The Budapest criteria include, for a diagnosis of CRPS, that there should be a continuing pain which is disproportionate to any inciting event. And the patient must report at least one symptoms in 3 of the 4 following categories. And the categories are sensory, with the reports of hyperalgesia and allodynia, vasomotor, such as temperature asymmetry, skin color changes, and skin color asymmetry, pseudomotor and edema, so edema or presence of increased or decreased sweating, and motor and trophic disturbances with autonomic dysfunction, such as changes of hair, nails, and skin, as well as motor disturbances. And then we need to find, upon examination, at least one sign in 2 or more of the same categories. So we need to find one sign in either sensory, vasomotor, pseudomotor edema, motor trophic category, and 2 of them to fulfill the Budapest criteria. But the most important part of the Budapest criteria is that there is no other diagnosis that better explains the signs and symptoms, meaning that differential diagnosis needs to be ruled out. So what kind of signs and symptoms do we have? We have the sensory symptoms with presence of hyperalgesia and allodynia to either heat, cold, mechanical stimuli, or pressure pain. Pressure pain is probably the most common sign and symptoms in CRPS, with the approximate frequency of 70%. The vasomotor signs include edema, which shows a distal generalization, which I will explain further. We can have increased or decreased blood flow, and of course, resulting in different skin temperatures. And the importance is that not the measurements just once, but also over time can detect differences in skin temperature. That is a problem because in the Budapest criteria, there's supposed to be a skin temperature difference that should be palpable, just without using any thermometer or something. We have pseudomotor and edema signs. As you can see here, you have an increased sweating on the affected extremity, and motor and trophic signs and symptoms. You can see that patients have difficulties to use the extremities. Fine motor skills are often disturbed, and in the upper extremity, fist closure is not possible. In the lower extremity, walking is extremely disturbed. The sensitivity and specificity of the Budapest clinical criteria that I just introduced to you is quite high. The sensitivity is 0.9%, specificity 0.6%. There are also Budapest research criteria that include that the observer needs to have one symptom in 3 instead of 2 categories. That but these have been shown to have a lower sensitivity and specificity. But they are much more specific than the formerly used JAS criteria. So when we now refer to what we agreed upon in Valencia for the better explanation how to use the Budapest criteria, it was suggested that for the asymmetry, it should also be a comparison to the opposite side, to the contralateral non-affected extremity. And in case there is bilateral CRPS, the signs and symptoms should be compared to an unaffected extremity. Then there's always discussion about spreading CRPS, and it was decided that spreading CRPS only applies if the affected extremities also fulfill all the Budapest criteria. Just having spreading of pain is not enough to talk about spreading CRPS. Regarding the point hyperalgesia, the pinprick stimulus is, when using a pinprick stimulus, hyperalgesia is defined when pain is felt more strongly or for a longer time than on the opposite side or an unaffected area. And most important, patients should be systematically asked about their symptoms. So you should always ask the patients about presence of symptoms. Allodynia is defined as pain as a result of normally non-painful stimulus. It can be present to heat, cold, mechanical stimulus, deep pressure, or vibration. And upon pressure pain, it was decided that the pressure should be as high as that the nail bed of the examiner turns white, which is corresponds to less than 100 grams per square centimeter. And if you compare it, for example, to the pressure you apply for the diagnosis of fibromyalgia, you apply a very much higher pressure with 4 kilograms upon square centimeter. So it's a very slight pressure. The skin temperature difference should be noticeable by touch alone. Skin color difference should be visible. And very important, the signs that are observed upon examination are not superior to symptoms. That means that if the examiner, for example, observes increased sweating of the extremity, but the patient has not told about increased sweating, then this sign is not superior to symptoms. So the symptoms can be not present, but the sign can be present. We also talked about CRPS subtypes. That still is an ongoing discussion. So far, we can differentiate between 2 types. CRPS type 1 without nerve lesion, CRPS type 2 with nerve lesion. But they are clinically identical, and we don't know whether this differentiation will be for any relevance in the future. One most important part, however, is that you really rule out differential diagnosis, and that includes the differential diagnosis of a neuralgia. And you can see here below that we have 2 patients. Both have had surgery for carpal tunnel syndrome. And on the left side, you see a patient with carpal tunnel syndrome and a median neuralgia after surgery, with presence of signs and symptoms in the innervation territory of the median nerve. And in case of CRPS, however, that differs. That would correspond to CRPS 2, but in that case, the patient would present signs and symptoms in the whole hand, like as symptoms and signs are distally generated, going beyond the innervation territory of the median nerve. We agreed on a new subtype, that is the CRPS with remission of some features, that corresponds to patients that have formally fulfilled the Budapest criteria, but do not anymore due to treatment. And the CRPS NOS, CRPS not otherwise specified, are in contrast patients that have never met Budapest criteria, but there's no other diagnosis that explains their symptoms. And that is, for my part, about the diagnosis of CRPS. And if you have questions, I'm happy to answer them.
Thank you very much, Janet. That's brilliant. So we've got opportunity for people to ask questions. We can, of course, ask ourselves questions as well if we don't have anyone else. I can't see anything. I can't see anything in the chat so far. So maybe, Janet, can I ask you, what's your most challenging case to differentiate between? Can you remember one where this is really challenging to differentiate between the neuropathic pain and then CRPS? Where do you think in practice is that for you particularly, challenging?
Oh, it's very challenging, and sometimes I'm surprised by the additional diagnosis. I remember one patient who had a clear radial nerve lesion after a shoulder tap, and she had so electrophysiologically we found the lesion of this radial nerve, and her symptoms and signs were present mostly in the innervation territory of the radial nerve, but they went slightly beyond that. The pain and also the movement disorders were not only restricted to the radial nerve, but nevertheless I said, okay, it could be a CRPS, and I of course treated, if I have it's suggestive of CRPS, I treat it like CRPS, but then I used the 3-phase bone scintigraphy as an additional objective measurement tool, and that clearly helps, because in that case the patient clearly had a positive 3-phase bone scintigraphy in the third phase, and that's it can be nothing else than CRPS. So in these cases I really also use also for insurance reasons 3-phase bone scintigraphy.
That's a great idea. So as a positive confirmation, as we know, it cannot be the diagnostic tool per se, but in these difficult cases, I mean, if it had been negative for clarity, you could still not be absolutely certain that it could still be CRPS, but in this positivity, you're rather certain that it cannot be just
something else,
just neuropathic pain. So that's a great idea. Thank you. Heike?
Yeah, I have a question. I think diagnosing the hyper or hypohidrosis is not so easy. I think hyperhidrosis, everybody has these cases where like the hands are dripping, but I don't know, maybe you can elaborate a little bit on this. I also find it difficult to say that there's less sweating.
That is really difficult. Yes, sometimes you can feel it in the palms of the hand when you just feel with your hands whether there is increased sweat. But the problem is mostly hypohidrosis. That's right, because sometimes you can only observe it when the skin, for example, is drier than the contralateral side. But that can also be a cause of trophic signs and symptoms. So these symptoms in that case mix a little bit. That's that's difficult. I think we have of course there are measurement tools that you can use, but they are difficult to use in CRPS because, for example, we have a measurement tool that measures on the palms of the hands, the sweating, and also on the feet. But the problem is that the patients often cannot put their hands planar on the measurement tool, so the measurement will not work.
Okay, yeah, good.
That's point. Really a problem. Yeah,
very good point, because I was thinking about buying something.
Yeah. It's an easy tool to use, but it's better for small fiber neuropathy and autonomic disturbances than in CRPS.
Yeah, right. Good point. Okay. Well, save some money.
Yeah.
Thank you very much. Just so we go to the next talk now. Thank you very much, Jana, for this great comprehensive overview on the clarifications with Valencia and about your introduction for CRPS. I just would like to remind the participants, so you can write questions into the chat, if you like. You don't have to, but you can, and we can see those, and we can pick them up, and we can then discuss them in the question and answer time afterwards. So if that's all right, then we go further now to Dr. Selina Johnson, who will speak about the CRPS EFIC web app. Thank you, Selina. Oh, maybe I can say we developed that with support from EFIC over a few years. I was also part of that team over a few years. I think the development ended already 3 years ago, and really thanks to EFIC for supporting us. It was not cheap to do this. We had a web company doing that with us, and it's only now, just now, that we have the final version online. But it's great because we have the additional feature now that there is now languages, all European languages. They have been translated with Google Translate. And so far, 6 languages have been cross-validated by pain specialists, and there have been virtually no changes. So those were common languages. And it looks like the Google Translate is quite good for that. So there will be eventually a post to say which languages are validated in that way. If you have a more rare European language and would like to help, please contact us, contact Melinda. We still need to do that. Thank you. And over to you, Selina.
Thank you. So I'm going to talk a little bit about the CRPS Assist, which is a free online tool for clinicians who may know a little bit about CRPS, but maybe need some guidance and perhaps don't have very easy access to that. So the goal of this is really to help patients with CRPS access care they deserve as quickly and as possible wherever they may live. So patients we all know as clinicians and people working with CRPS that we often hear that patients report difficulties in accessing diagnosis and treatment. And I think this is in part because it's quite a rare condition. And most clinicians who don't specialize in this will maybe see patients with CRPS only occasionally in their career, and therefore maybe have limited knowledge and expertise in what it is. So the CRPS Assist is really to provide fast access to expert advice that can help clinicians to identify what CRPS is and decide what to do next. And I'm going to go through some of the features and sort of how we developed it a little bit as well. So if we consider why we felt it was needed, well, we are aware that there's lots of international guidelines out there for CRPS, and all the guidelines strongly recommend therapy for the mainstay treatment for CRPS. But the guidelines are limited in what they can do. They can't go into great depth as to what the treatment is, what in respect to treatment techniques and who may benefit and how to deliver it and the timing of that. We also know that often clinicians report that they maybe have limited experience in this condition and sometimes describe not feeling hugely confident in how to manage it. And there's lots of evidence out there to support this. So quite recently, the ENACT study, which was conducted by the Bath research team in the UK, explored the management of CRPS across the pathway. And they interviewed lots of clinicians who work with people who have CRPS, and despite experience with CRPS, they often found that people maybe didn't feel hugely confident in identifying CRPS. And so one of the main findings from this research was there was a recognised need to increase awareness about the condition and also improve education. We similarly found in 2017, we conducted a Freedom of Information Act and found that 82% of English centres with CRPS relevant services had no CRPS care pathways or agreed initial management criteria. So it's as much as the conditions out there, maybe it's not supported by practice. Also, the last study listed on this slide shows a couple of international surveys of clinicians, and what they found was that clinicians tend to use a broad range of modalities with little consistency. So treatments are being applied, but often, probably due to lack of experience, people aren't quite sure when and for who. Therefore, we felt something was needed to help with this, to help people recognise what CRPS is, to consider what can be done and how to do it, and also to develop that this should maybe be in the form of a resource that could support clinicians, support clinical reasoning and treatment selection. It was really important that it's easy to use, easily accessible, and that the information clinicians could find easily in one place. So as Andreas already said, there was a small working group, and that was clinicians, including myself. I'm from a chronic pain background, but we also had clinicians who worked with CRPS from acute pain backgrounds as well, so who worked in fracture clinics, and also supported by Professor Goebel as well. And we worked with a web and online development company to develop this research, and they helped us to really make our sort of ideas of what would be useful to clinicians develop into a usable format. When it was developed, it was sent for peer review via various clinical experts and also the CRPS network, and was slightly refined till we got this final version. As Andrea said, it's in the development now of being translated into lots of different languages so that it is accessible and lots of people can use it. And these are the languages listed on the online tool now that it's being developed for. So what does it look like? Well, when you click on the link, you get taken to this first holding page, and there's various boxes there that you can select. So if you think, what is CRPS? If you clicked on that, it would take you to this sort of page, which explains just briefly what CRPS is, but then breaks it down into different domains. So who does it affect? What's the incidence? What causes it? And how it can be prevented and cured. So when you click on, you're given digestible information, not reams and reams of information, but information in a brief format that hopefully clinicians can take away and find useful. In terms of diagnosis, so does my patient have CRPS? We thought it was really important to have something that reflected the Budapest diagnosis criteria, but people could use in clinic. So this link takes you to a downloadable version of the Budapest criteria, but also an inbuilt checklist. So if somebody's sat there in clinic with you, or you've seen a patient in clinic, you can then go back and you can click all of those symptoms that Janine's just gone through really. Does this patient have the signs? Does they have the symptoms? And you can select and tick the boxes. It very cleverly then calculates from the responses that you've inputted whether there is a chance that your patient has CRPS or whether it's an unlikely chance that that patient has CRPS. So it's a nice usable tool that people can use in clinic. Following down from that, there is another box that says, should I give my patient a diagnosis and how should I do this? And I think what's important in this section is it highlights that many patients will consult Google and get worried about all the information that they can access there. So it really recommends that patients should follow the European Task Force Standards of Diagnosis for CRPS. And these include making sure that patients and their relatives have got adequate information, and this information should include what CRPS is and the limits of current scientific knowledge, what the natural course of it is likely to look like, what signs and symptoms that could include and what they may feel like and look like for them, what may be the typical outcomes, and what are the treatment options available. And there's an emphasis that the information here should be on goals of treatment and the patient being actively involved in those goals. On these boxes as well, there's also included links to patient information and information for clinicians on how to explain the diagnosis as well. So there's further resources to support the brief information that's on there as well. Another section here is important section is where do I start managing CRPS? So when we click on this, it breaks it down to the most to symptoms and then some other aspects. So when you click on symptoms to manage, you can see all the symptoms that are listed in the diagnostic criteria that has just been discussed. And if you click on each of those symptoms, it will explain what it looks like, how maybe patients may describe some of these symptoms, how to assess them, and then links on how to treat them. I'm going to go on to talk a little bit about the treatment there, but just want to come back to these important sections here: psychological support and patient examples. So within if you click on psychological support, it highlights things to consider to make sure that clinicians are working in a psychologically informed way. So it's got a few key points there, but also it importantly highlights the need to refer to psychology and onto psychology services if there is quite high levels of distress or depression. That MDT approach is needed. And we've also got some links to some patient examples, so some case studies where some of these symptoms are highlighted, but also where some of these treatments are explored as well. So where do I start managing CRPS? If we think for each of the treatments, it describes an overview of what the treatment is, when to consider the treatment, how to do the treatment, but then most importantly, some do's and don'ts and top tips. And I think that's really important when we're considering some really commonly known treatments, such as mirror box therapies, often talked about with CRPS. And people know that, they know that that's out there and the evidence is there to support it. But actually, sometimes as clinicians, we hear mirror box therapy not being done particularly well, or patients not understanding quite why they're doing it. So for treatments like that, I think it's really important to have some guidelines as to some key top tips, some things to avoid, some things to include to make sure that that goes well. So the key features are, well, it gives a bit of an overview of what the app, the online tool includes. But really, I think probably what's best to do is to follow the link and explore it for yourselves. I think what's useful on the tool, hopefully, is the links to diagnosis. We hope that that's useful in clinic if people need quick access to things, or just reminding of sort of what is required to fulfill that diagnostic criteria. There's also links to the guidelines as well, for further information, and also obviously in the guidelines there's lots of relevant literature as well, so it enables people to take on extra information in their own time as well. There's also links to information that can be shared with both clinicians and patients as well, so some example bits of information there that hopefully people can take away and use quite practically. I think the patient examples are really useful to help contextualize how to introduce and progress some of the treatment, and it provides some ideas as a starting point. There is an emphasis as well throughout the app on when to refer or to seek further help. So we are encouraging people, if they see somebody and they don't see any progress in a couple of sessions, to refer on for specialist advice or seek specialist advice before discharging people and telling them that nothing further can be done. And I suppose the big caveat here as well is it's not a replacement for clinical experience, but it's really just a tool to help guide and support clinicians. So again, there's the link to the tool, and I suppose what's left to say is to please share and use it, and particularly this month, with it being CRPS Awareness Month. Thank you.
Thank you very much, Selina, for this great overview over this super resource, which I'm so pleased that EFIC could support us for. There were a couple of questions. One was, can everyone, that has this, you have already responded, it looks like, no. Does CRPS, but I thought this is an important one. Does CRPS need to be diagnosed by a medical doctor, or can other pain clinicians assess it and diagnose it? I suppose we give that open to the panel. What do we think? We've got in the UK guidance, we've got our view on that. What do you think, Heike and Janne?
I think for Germany, the final diagnosis should be made by a physician, definitely, in order to be recognized by the health insurance companies. But I don't know how it works in different countries.
Yeah.
I mean, the criteria can be used by everyone, and there's no need that a physician needs to use these criteria.
Yeah.
Only.
So,
yeah.
I would also like to comment on this. I think the diagnosis in the end has to be confirmed by a doctor, especially because you have to prescribe you have to do the prescriptions and everything. And sometimes I think it's not so easy if you have someone who's been diagnosed with a CRPS. I think, as you also said, people will go to the internet, and it might not be the best source for information, and then they are very worried, and then they come to your clinic. So I think one has to be careful with this diagnosis.
yeah. Okay, Selina, do you have a comment on that?
I think we've included on the online tool as well that actually it should be, you should consider your professional boundaries really, and what you're sort of comfortable with. So in certain countries, it definitely, the diagnosis should be delivered by a doctor, but in other places as well, if you've got the support of a specialist team and you can refer to things, then it may be that specialist clinicians or physiotherapists are able to deliver that diagnosis. But again, if we're not sure, then don't necessarily deliver the diagnosis, but maybe indicate that, you know, we can treat some of these features because maybe it looks a little bit like this.
Yeah, and I suppose one of our objectives was to also at least empower people to raise a suspicion of CRPS, yeah, so that it's not just the doctor who can come up with the idea this could be CRPS, and then you know, check with your team. But we actually want to encourage people. I think that was our including particularly physiotherapists, because often they are the first ones to see this. It doesn't always come just after trauma. It can come after smaller things like minor trauma and so on. So at least, you know, do use the criteria, and then maybe ask your clinical specialist, which probably often is a doctor, you know, whether they can confirm it. But it's we would like to encourage people to be aware of it and use these criteria, as Heike has also said. Thank you. So I think there was one a question here: is CRPS dangerous? But I think it's not by itself. It's not by itself life-threatening a condition. I don't know where this came from, but no, that doesn't have that aspect to it. But people can get quite desperate with it. That's by you know, it's difficult to live with. So thank you very much, Selina. I'll hand over now to Janne for the first case presentation. Thank you, Janne.
Yeah. I will give you, I have presented two cases, and maybe I want to give another comment to what we have discussed further. The problem is that you really can diagnose CRPS only after 3 months of the initiating event. And the time in between, there are lots of conditions that look similar like CRPS, and that at the end develop totally normal. That is, I cannot specify it. Maybe we can discuss it at the end as well. It's kind of a delayed healing process, whatever is the reason for that. It can look like CRPS, but it's often not as severe, and the pain is not as much as in real CRPS. Of course, you should treat it like CRPS when it is suspicious, and then monitor it, and then you will see whether it develops in the right or the wrong direction. So yeah, I will start with one case. It's the question is this CRPS? It was a 27-year-old woman. She had recurrent pulmonary artery embolism and thrombosis, and was on anticoagulation. She got a horse kick on her right hand, and due to anticoagulation, a big hematoma that needed to be treated by surgery. She had an open carpal tunnel roof splitting and neurosis of the ulnar portion of the median nerve, and a wound revision and hematoma evacuation. So she had a complex reaction after the surgery and a complex cause of the disease. She developed pain and edema on the whole right forearm that was progressive, and there was no effect from treatment. Someone had already tried to give gabapentin, tapentadol, and prednisolone because he suspected CRPS, but that did not have any effect. And then she was sent to our clinic. She presented with burning, shooting pain of an intensity of 7 to 9 and was massively limited in the usability of the right hand. Upon examination, she had edema and redness of her right hand and forearm. She had a severe mechanical allodynia and hyperalgesia in the whole area, and a slightly reduced hair growth on the right forearm. And when you remember the Budapest criteria, together with a decreased range of motion, we could clinically diagnose CRPS. But then we had a look on her. We told her to pull out her pullover, and I saw this lesion, whatever, stream on the upper arm. And as you see here, you can clearly see that there is something probably artificially made by her to just comprise the arm like a tourniquet, so that the arm below was presented with edema and redness. And you can maybe also see that there are some little scarves on the arm. So when we further looked at her, we also saw, and you can see it here, that her whole abdomen had severe scars that really looked horrible. And it turned out that it was an artificially syndrome. Because she always had a tourniquet put on her arm, and that, of course, led to signs and symptoms that looked similar than CRPS, but of course it was not a CRPS, it was an artificially induced syndrome. But we were only able to diagnose this upon observation within a 2 weeks inpatient treatment to really see what the problems are within a multimodal diagnostic procedure. But I will now focus on another presence. It's another really rare case of real CRPS in that case that you guys have also published in Pain Medicine 2 years ago. And that was a 50-year-old man with a known seronegative spondyloarthropathy associated with known Crohn's disease. And he had, due to the spondyloarthropathy, recurrent pain, swelling, redness, hypothermia, and all extremities for many years that always immediately responded to short-term treatment with prednisolone. And then on December 21, he had right thumb surgery for its arthrosis, I think. And after that, he had severe pain, swelling, redness, hypothermia, movement restrictions distributed in a glove-like manner on the right hand, so not only limited to the thumb where the surgery was, but also to the whole hand. And there was no sustained symptom reduction after prednisolone treatment as it used to be before. And a discontinuation of prednisolone treatment resulted always in rapid release of symptoms, but in this case it did not. There was always the discontinuation should lead to a rapid exacerbation of symptoms. And after 3 prednisolone cycles, the rheumatologist sent them to us with the question whether there was presence of CRPS. And when the patient came on his first appointment in March, so 3 months after surgery, it was 1 day after prednisolone had ended. He was pain-free. I was a little surprised that this patient was sent to us because he did really have nothing. His hand appeared completely normal. There were no autonomic signs, no hyperalgesia, no mechanical allodynia. All movements were possible. The patient was completely symptom-free. We also made a quantitative sensory testing, and you can see here that on the right hand, of course, there's some loss in the small fibers, but upon the pain thresholds, all thresholds on the right hand are totally normal. There was no abnormality detected. Then I told him, okay, in case the symptoms come back, because it was 1 day after cortisone treatment, then just call us and you can just immediately come to our clinic. 1 week later, he called and he came to the second appointment. with now he had severe pain, shooting and burning in the whole right hand. He had edema, temperature differences of more than 4 degrees Celsius on the right hand compared to left, redness, increased sweating. And we had also a QST on this appointment. And now you can see that he has cold pain, hyperalgesia, severe pressure pain, hyperalgesia, and compared to the contralateral unaffected extremity, also mechanical pain sensitivity within 1 week after discontinuation of prednisolone. This was his movements. He was not able to make a fist closure on the right hand due to severe pain and because movement wasn't possible. So then I decided that we immediately need a 3-phase bone scintigraphy because I wanted to see what's going on there. And we made the scintigraphy, and you can see here the third so-called late phase of the 3-phase bone scintigraphy. And you can see in this phase the tracer uptake in the bone metabolism. And when you compare right to left hand, you see that there's a high amount of activity in the radial, in the wrist, and also compared to the left hand in the small finger joints. And if you, that's not a very good picture now, but if you use the region of interest compared between affected and unaffected extremity, you can get a ratio, and with this ratio, you can get information about sensitivity for the diagnosis of CRPS. And in this case, you can see that the tracer activity is high on the right hand and all the small finger joints, which is a typical picture of CRPS. So then I told them, okay, we now have CRPS, we need to treat it. And I gave him pregabalin just for the treatment. But he came back and said, okay, so far it doesn't there's no effect, but I promise you that if you prescribe me cortisone, the signs and symptoms will be gone tomorrow. So I prescribed him cortisone, and a few days later, after treatment with cortisone, he came back, and his pain at rest had completely disappeared. He had the pain during exercise had decreased. Of course, the inflammatory symptoms had regressed because cortisone is an anti-inflammatory substance, and a fist closure was now possible. And I will show you later a video about that. And the quantitative sensory testing profile had now a little bit normalized. There's still cold hyperalgesia, presence of cold hyperalgesia, but for example, the pressure pain hyperalgesia completely resolved compared to the week before. So then this is the movement that were now possible after the short-term treatment with cortisone. And you see that he can now easily make a fist. And that is really an unusual reaction and unusual cause of CRPS, because this rapid fluctuating cause of disease is rather unusual. But since 3-phase bone scintigraphy was positive, there's no other diagnosis possible. So we continued to give him 5 milligrams of prednisolone per day for 5 months, because when we were afraid that when we stop this medication that the symptoms will come back. And after 3 months, he was completely pain-free. He sometimes had rare shooting pain episodes in the wrist with movements, but there were no autonomic abnormalities. Hand and finger motion was totally unrestricted, and he had improvements in the quantitative sensory testing. And after the 5 months, we could stop cortisone treatment, and he didn't have any more symptoms. And I think this is a very interesting case, because it shows that it can be rapid fluctuating. And I had a look on PubMed for this case, and there was another case published right before our case about a patient with psoriatic arthritis and complex regional pain syndrome. And it was the same case. They also had a trace bone scintigraphy for verification of diagnosis, and they observed the exact same cause of the disease. And they found out that since psoriasis and the rheumatoid arthritis are also associated with inflammatory mechanisms, that trauma as well as inflammatory mechanisms can release or can lead to inflammatory mechanisms that are similar. Both on the one side, there is psoriasis or rheumatoid arthritis that can trigger CRPS, and on the other hand, a trauma that can trigger CRPS can also trigger psoriasis and rheumatoid arthritis. So there's a interaction between autoimmune diseases and CRPS, and I think that's very interesting also with regard to Andreas' research findings with autoantibodies in CRPS and autoimmune treatments. So that was my case. This is Kiel, and I thank you for your attention.
Thank you very much, Janne. That was really great 2 cases, and I'm really pleased actually that you have presented them. There were a few questions from the audience. The first one is, could you please elaborate further on what the artificially induced syndrome is? And understandably, that listener has not heard about this before.
It's a severe psychiatric disorder. In patients, it can occur together with, for example, borderline personality disorder, but this doesn't need to be always co-expressed with it. It's just a primary psychiatric diagnosis that patients, for different reasons, seek for medical attention, or there's a conversion disorder. That means that they totally distract from the extremities, and they are often very difficult to treat, these diagnoses, because
and if I might ask, so I have only, they are rare. I think you've probably alluded to, there are a couple of case presentations published, including the Canadian study from Maylis, where there are some of these self-induced CRPSs described. They can have the rare psychiatric diagnosis of what in English is called factitious disorder. I'm not sure how that is called in Germany, but and that's really a psychiatric disorder. And if they have that, then it's a severe disorder, as Janne says. It's, you know, one might think, oh well, they just get over it, but they don't. And they can be quite persuasive in their presentation. So I've only seen 2 in my time, and this gets us back to the diagnosis, isn't it? So I certainly didn't recognize this initially in one of them. In the other one, but whenever you have, I don't know about you, but whenever I had these 2, it's almost like it's like a jolt. Oh my God, you know, this person is doing that to themselves. So it's completely out of the normal clinical thinking. And you just certainly have to switch your thinking into something different. And the other patient that I had, I did not recognize it until I had him on the table for a spinal cord stimulator trial. So that's how, and I would say that I'm usually quite careful in assessing people, but it was only then that I could see that this was induced, and thanks God we saw it then, because he couldn't hide it in the theater. And so I could, you know, then I stopped it on the theater. We didn't get the spinal cord stimulator in. So these patients really, they are not quite clear in their mind in that sense. There's something that it can be very hard to diagnose.
And it's also a problem. You should never confront them with the artificially disease. You should take it as is, and then
refer to psychiatrists, but they might not
for treatment. You can explain that there's a biopsychosocial model of pain, and in their case, the psychosocial parts are the ones that can improve their situation best, for example, somehow like this, because otherwise it will not have any effect.
Yeah.
Because they sometimes don't do it. They do it artificially, but the reason behind it needs to be explored further by a psychologist.
Yeah, and they will resist that, obviously, and so that it's not that easy. So yeah, thank you. Then there's another question here, which is maybe related. Do you believe that there are similarities between CRPS and functional neurological disorder with regards to the underlying mechanism? That's just to say that's something completely different from from a factitious disorder, just to clarify that. But then do you think there's anything similarities between CRPS and functional neurological disorder?
Similarities, no, I don't think so. But I think that the comorbidity of psychiatric diseases can be high in CRPS, and there are a lot of patients with severe courses of diseases that, from my experience, have a high amount of additional psychiatric diagnosis. But
it's not the same. Yeah,
it's definitely not the same.
Yeah. Thank you. And then another question: the role. Why did I suppose it means? Can you elucidate why you chose prednisolone in your second patient rather than zoledronic acid or another bisphosphonate? And also, can you comment on the use of vitamin? Well, no, actually, that can come later. That's a different.
Okay, so we usually don't use biphosphonates very often because we don't need them. We have other substances that we use, and I always treat with prednisolone when I have inflammatory symptoms of CRPS, because I think it's for the inflammatory component a better treatment from my experience.
Okay, and then another question: can you comment on the use of vitamin C? That is the last question we can take now, in the prevention of CRPS post-radial fracture.
Yes, there are lots of published articles in the last years that have suggested a prevention of CRPS by the use of 1 gram vitamin C per day for 3 months, for example. And I give it to every patient because it has no negative results. It's a water-soluble vitamin that is released by urination, so there's no overuse or overdose of vitamin C, and you can use it very good as an additional treatment, not a treatment alone, but as an additional treatment. I use it all the time.
Okay, lovely. Thank you very much. Sorry, we won't have more time at the moment. There's one question which is specific for motor disorders, symptoms in CRPS. Could there be FND underlying? That's a super specialized area. I've seen that in medical legal cases. We won't have time now to elucidate that, but it's clear that it's a different condition. So I think it's now me doing my presentation. So if I just share my screen, if I can still find it. It's probably this one, I suppose. Hopefully, share. Yeah, okay. So I'm going to talk about presentations of CRPS with widespread pain. But I'm sorry, I have to just get well, I just have to pause this for 1 second. Just 1 second, I'll be right back. And I'm so sorry, that's my little daughter who went to the wrong dentist, so I have had to ask my wife to do this now. So I'll say something about my own patients where we looked at this question. We'll show a few case examples and then make a few suggestions. So we looked at, in my own patients, whether we had patients, because in clinical practice, it appears to me, seeing mostly people with widespread pain, with long-standing CRPS, sorry, that actually quite often people then also develop more widespread pains. And it seems, when looking at all our cases, even then already over 5 years, that some people develop indeed widespread pain, additional pains, which are not associated with Budapest signs, And we've heard from Heike that if they're not associated with Budapest signs, we shouldn't call them CRPS. But they are sometimes described in neuropathic terms, so sometimes people describe them as if they were CRPS. They say it's exactly the same pain, but they won't have Budapest signs in these newly developing areas. In my cohort then at that time, the frequency was about 10%, and I see mostly people with persistent CRPS. Independently, people can develop compensatory pains or referred pains, which are different to these secondary widespread pains. So, for example, if they have a pain in the foot, a CRPS pain in the foot, they might use the other foot more and develop pain there. And then we unexpectedly also found that a subgroup of patients had experienced non-CRPS chronic unexplained pains a couple of years, usually a few years, between 1, 2, 3 years prior to the CRPS onset in the later CRPS affected part. So then later had another trauma and operation, maybe even for that unexpected pain, that then the surgeon said, oh, we just nibble away this little bit here, and then the CRPS started. So it's interesting, what was that then? What was it that was preceding this? But what I show you here is not representative for the general CRPS population, because the patients that I see are usually more than a year into their condition, and as we know, many patients have a strong improvement earlier than that, between 3 and 12 or 18 months. So, but what I would like to show is that these widespread pains can be quite bothersome to patients' quality of life. So we ask them, how important are they to you? And they, in terms of the primary so we call them primary chronic widespread pains. So those are patients who have first chronic widespread pains and then develop CRPS. So that was quite frequent, and then they were the same importance in many patients. In other, CRPS was more important, and these are the ones that I've just discussed, the ones that had first CRPS and then developed widespread pains. And again, quite a lot of them said these widespread pains now, even so they're not CRPS as per definition, they're still about as important to my quality of life as the CRPS pain, which is interesting because one always thinks, of course, that because CRPS pain is so strong that this is not possible. So here's my first case example. I just want to have a bit of a nicer pointer here. So let's see if this works. And this is all writing. I don't have nice pictures, I'm afraid. So a 40-year-old lady, right knee pain since teenage years. And you can see here again, here it was clear why she had the right knee pain. She had a condition called osteochondromatosis. But interestingly, and that's where small cartilage built up in the joint. But she did have some other pains which didn't quite fit osteochondromatosis related pain. So when she had in the shower water, then that often burned. But she could manage that. And then she had lots of keyhole surgeries, which she needed for this condition. And after the first operation, had quite a lot more pain, burning pain now. And this is what I mean. Often people present with some pain, which is sufficiently bothersome that they go to the doctors, and the doctors do something, do an operation, and suddenly the pain is getting really bothersome. And the intensity was now 10 out of 10. So this was this part to what we found as an example. So here, regional pain, probably not CRPS to start with, then becomes CRPS. They continued to operate, and the pain got worse and worse. We offered her a spinal cord stimulator treatment, which helped her to start making some functional recovery. This, based on our autoantibody findings, this lady responded really well to this, but she's really the person that best responded to it. And it's, in my hands, often not working that well, particularly because plasma exchange, she responded to plasma exchange, sorry. The plasma exchange also has some side effects in these patients because of the large cannula. But this is the reason I'm showing this is because after her last plasma exchange cycle, and every time her pain goes down from about a 9 out of 10 to a 2 out of 10, and she can then for a year work. She's gone back to work after her first cycle after 7 years, and she works throughout now and is back. But now this time, when again this worked, but 4 weeks after that, She now developed an onset of new left groin pain, new back pain, also left-sided lower leg pain, which all these pains, including in the back, had this CRPS character of really intense burning and squeezing, I think. There was maybe a bit of a sign in the left leg. If you remember, the start was in the right side. Yeah. But the other areas had no CRPS elements to it. I forgot to say that here, just a little point about generalization in patients who have knee CRPS, and that's only now recognized really as an entity. It wasn't 20 years ago. It's due to the work of Frank Huygen and others. We see these patients, often they start with knee and then become distally generalized. That happened to her as well. I forgot to say that, sorry. So she also, at the time when this happened with the spread of pain, yeah, she also had then clearly increased systemic symptoms, including this digestive problems like almost irritable bowel-like nausea, but she didn't really have fibromyalgia pains all over her body. So in conclusion, what was this CRPS preceding pain? It wasn't purely nociceptive. Distal, so knee CRPS spreading to become distally generalized is, in my practice, relatively common. There are new onset pains, maybe on the left side with CRPS signs. So maybe we could say that's spreading CRPS, but then they're in the groin and in the back, and there's quite a large back area affected for her. There were clearly no CRPS sign, and we are not sure whether that even exists, CRPS in the back. So how should we class that? Is that coincidental? And then she had also somatic symptoms. In the second example, 50-year-old lady with intermittent chronic back pains, no other chronic pains, and she slipped on a wet ground and sustained a left ankle fracture. She developed CRPS of foot and ankle within 2 weeks. Well, Heike said actually we cannot diagnose this within the first 3 months. So for us, we usually say within the first 4 weeks. So I shouldn't have said within 2 weeks, but then in retrospect, one can say, you know, that was already CRPS. It wasn't Heike, it was Jan who said that, yeah. The condition persisted despite appropriate physiotherapy, and it was then that we confirmed this diagnosis when she came to us. She was very distressed. She attended the pain management program with good success. The pain was still the same, no spread of CRPS at that point. And then in June 23, she continued to complain of constant aching back pain. But if you remember, she had that from the start. And we attributed that at this point to walking differently, compensatory. And she now wanted to have spinal cord stimulator treatment. And we reassessed her effectively 3.5 years after onset. And we assessed her for spinal cord stimulator treatment. And in the course of that assessment, we looked at a new GP summary letter from her general practitioner, where it was noted, and patients never tell us this, that she also had a recent orthopedic right shoulder assessment. And then also left knee pain documented a bit earlier, and steroid injection for another pain. So it looked like, even though she hasn't said that initially, she didn't say that there were some other pains. We inquired then about this, and I asked her, you know, if you take all your other pains, back, knee, and so on together, shoulder together, and she gave that a pain intensity of 6.5 out of 10. Different character pain, more aching, sharp pain, and I diagnosed chronic widespread pain at that point. And on balance, then spinal cord treatment, I thought, wasn't suitable, because if we can just help with this one CRPS pain, it's, in my experience, clear that patients will still complain about these other pains afterwards. That's my practice. And also, if people have widespread pain, then usually the pockets from the spinal cord stimulator can become quite painful. So, so she had concomitant MSK pains in the body that can, in my experience, slowly creep up and become sometimes as important as a CRPS pain for some patients. These pains need to be distinguished from compensatory pains. I don't think they were just because she was walking differently. I think she developed a different additional pain condition. I don't know how that should be called. Maybe it's coincidental that she did that, or is it just CRPS plus MSK as part of the CRPS? It's important to ask people about this because especially some interventions then are not suitable anymore. So overall, I do try to routinely inquire about other chronic pains that preceded CRPS or that later developed. Intuitively, one doesn't want to do that because CRPS is so much in your face, it's so intense that one thinks, oh no, surely nothing else can be really matter. But I try to do this. I also routinely inquire about systemic symptoms. It's interesting, people with CRPS do have fatigue, not as much as fibromyalgia, but there is a subgroup that have also memory problems, fatigue, and at least to recognize that for our patients. And then, just to summarize, as just said, patients with persistent CRPS can often or with some regularity develop CRPS type pains in other body parts, but without Budapest symptoms. And these other pains can be as relevant to the quality of life as the CRPS. Is that part of the CRPS condition? Should we find a name for this? And then finally, some patients will actually develop MSK type pains, so not CRPS-like pains when they have CRPS. And these could be maybe compensatory or referred, or not compensatory and not referred. Okay, and that's it. Thank you very much. And I'm just going to stop sharing now. Okay. So maybe I can ask someone else to ask me questions. I don't know. Is there any questions? Otherwise, we just...
I think until now, we don't have certain specific questions besides the one that are already answered.
Okay, good.
Can I ask a question?
Yeah, klar, of course.
Maybe I missed this. So what do you think on what's your percentage of patients on these chronic patients that have CRPS and something in addition? You think there's a lot of overlap? Sorry, maybe I missed this in your talk. Or you think...
I said in the beginning, when we tested this in 2013, it was about 10%. So not 10%. That high, but my clinical feel is we should really repeat it. I'd say it's more towards 20% now. Develop these additional symptoms. And there's another group that already before, so we've also got some patients that had already fibromyalgia before and now truly develop CRPS. They clearly have CRPS, which is another group. And then again, that's maybe 5 to 10% of my patients. And in these cases, I haven't alluded to that, often the CRPS will slowly go down again and sort of almost like a wave go back into the general misery of fibromyalgia, you know, about this. Yeah.
Do you think they have a common pathophysiology, or you think they're the special subgroup or something?
Yeah, so something related with the fibromyalgia. There's got to be a related, something related. But, you know, the intriguing ones are, for me, more also the ones that have really typical CRPS pains in other parts. Sometimes there's a few patients that get it all over their body. One reason to say that here as well is that people outside in the community might recognize that and not think, oh, the patient is, you know, sometimes one says, oh, that doesn't fit or so. And we haven't described this enough. It's just a phenomenon. I don't know why that is. Yeah.
Maybe it's a sensitization of the nociceptive system and then leading to some kind of nociplastic pain. I don't know.
Yeah, well, maybe that's one explanation for sure. Yeah. Okay.
I think we have a question now. Let me see. Oh, maybe not.
Just say thanks. Okay.
Oh, okay.
So maybe.
Oh, there's one.
Okay.
May you please describe the 3 stages of CRPS?
Yeah, that's a good question.
Okay, that's a question that's quite good because, okay.
So we are not, so we thanks for the question. It's good. We are not necessarily using that anymore now as stages. So that was very, it's still in the literature sometimes, and people talk about stages of CRPS, but that has been disproven the existence of such stages. And so one cannot say that there are stereotyped stages of CRPS anymore. So I'm certainly not using a stage model of CRPS, and looks like the others also don't.
Yeah.
Probably better to talk about acute and chronic, although it's not defined what is acute and chronic. It's more related to the signs and symptoms present. So if you have a patient with severe inflammatory signs, it's rather seen as being acute. And those without more than chronic, but that is not defined so far.
Yeah. Okay, thank you very much. So maybe if we now come to our last talk from Professor Heike Rittner, if I can hand over to you, Heike.
Yeah, absolutely. Yeah, thank you, Andreas, for organizing this great symposium and discussing clinical cases. I have one case presentation with a patient, and he's a 77-year-old man, so not the classical one. He came to our clinic with a chief complaint of pain in the upper extremity. He was has normal weight and normal height. These are some copies out of the German pain questionnaire, and I translated this here. So the palm had some stinging pain and pulsating pain, and it felt numb. The two fingers, the fingers 2 and 3, also had some pressure pain, and the first one was just numb. The thumb, and he had no strength below the elbow. So it didn't quite look like CRPS, but we were further looking at this questionnaire. So when we sorted out the pain characteristics, so that's what the patient actually also he marks. He marked stinging, burning, hot, and pulsating, and apparently it was a constant pain with different levels. So it was waxing and waning within 1 day. He had continuous pain of 6 and maximum pain of 8. So there was quite some suffering. Pain relief was massaging or lymph drainage treatment, and it was exacerbated by movement. If we look at the history of the patient, there was not much in this arm. He had a surgery and many years ago, so 21, 22 years ago, which with an abscess, nothing in between, and he had a traumatic amputation of the index finger because I think he was working on wood, but this had nothing to do with the incident now, but he had a total shoulder replacement in May this year. His comorbidities included diabetes, arterial hypertension, and hypercholesterolemia. And these are his drugs. So they're the regular ones. So he was taking some low-dose aspirin. He had pregabalin. These are drugs for hypercholesterolemia and to lower the blood pressure. And here's the insulin. And he was taking metformin for his diabetes. And this was the clinical examination. The right hand was the one which was affected, and indeed, if you remember, the amputation was on the other side. He had this burning pain. He had hyperalgesia and allodynia. The numbness was mostly in the area of the median nerve, but the swelling was everywhere on his hands. The discoloration was also everywhere on the hand, was not confined to the area of the median nerve. The skin was thicker. He had reduced nail growth. And you can see here that he couldn't make a complete fist, and also his wrist movement was impaired to both extension and flexion. So we said, okay, in the hand, the Budapest criteria are fulfilled, but there's no trauma in this area. And we also checked for the CRPS severity score, which was 11 out of 16. Because the patient was in our pain clinic, I can also give you more background. So we had a psychological assessment. So he was married. His wife was suffering from depression, 2 children, 3 grandchildren. The childhood was somewhat eventful because his father died when he was 11, and there were some physical assaults. I thought it was maybe the time when this was still part of education, of bringing up children. He was a letterpress printer, but retired 12 years ago. He was suffering from insomnia, so he couldn't sleep very well. He had some difficulties of concentrating and noticed himself to be irritable. And we looked at the questionnaire that we usually use with the German pain questionnaire, and we found some mild depressive symptoms, no stress, no anxiety, and there were some suicidal thoughts. In summary, our psychotherapist made the diagnosis of chronic pain with mental and social stress factors. We didn't really see a clinical relevant depression. We also had the physiotherapy assessment, which was a lot more than what I wrote down there. I thought it was interesting. I like the grip strength test because you can really see that it's a lot less on the right side. And we did it's not the 7, but the 9 peg hole test. And he was only able to do 2 pegs in 1 minute. Most of the other physical examination from the physiotherapy was quite appropriate. And we like to ask patients for patient-specific function scales. So what do they want to achieve when they are in our multimodal interdisciplinary pain program? And it was all concerned about his hands. So he wanted to completely move his hand, to move his fingers and pick up an object. We also did some examinations. We did electrophysiology, and the neurologists told us that there's an axonal lesion of the sensory and motor nerves of the median nerve. There was also a sensory lesion of the ulnar nerve, but the radial nerve was intact. And the summary of what the neurologists told us that this could have been part of the, or while they were doing the total shoulder replacement. When he came to us, he already had a steroid pulse in July, so this was done. He came with pregabalin, tilidin, and ibuprofen as needed. And the diagnosis we made was CRPS type 2, and it was a warm CRPS. We thought that there was a traumatic injury of the median nerve after shoulder surgery, and we diagnosed chronic pain with mental and social stress factors and metabolic syndrome. So this was when we did our assessment. And then the question was, what are we doing with it? What did we do with him? We made a treatment plan with a focus in the CRPS program. The plan was to increase pregabalin, and we were thinking about antidepressants. Our physiotherapy did education, and we are really quite excited about graded motor imagery, and I put the app here. So he was really good in doing this. He did by himself mirror therapy already, because I think when he was in ambulatory pain treatment, one of the occupational therapists started with this, and he had a lot of active exercises. In fact, this is a patient which is more of that type who's doing too much instead of doing not enough. So our job, especially in physiotherapy, was rather to slow him down a little bit. The patient also got psychotherapy, which was education and stress management. And in terms of the drug therapy, we just increased the pregabalin and no additional medication. And I think he just benefited from the whole program. In fact, he is still in the pain clinic, so I can't tell you what the final outcome was, but it was good. What we were mostly puzzled about, there were no symptoms whatsoever at the site of the surgery. And although I said we made the diagnosis of CRPS, I still think it's quite far away, so there was nothing on the right hand. And with this, I would just like to thank people who are doing all this work here, and yeah, looking forward for the discussion.
Thank you very much, Heike. Really interesting case, and and that's we've discussed something similar before. It seems like quite a number of us see that sometimes in clinical practice. So I know you said maybe if I may start, you said that you made the diagnosis initially, but you are baffled by the fact that the injury is remote from. So would you still today nevertheless still say that this is CRPS? Would you still stand by it?
Yeah, I think, I mean, when we started, we didn't quite know about how was the surgery related to the hand symptoms. But since we looked a little bit more into the techniques of the surgery and talked to our neurologist, there was, they said it could have been, I mean, the patient had no symptoms before the surgery. So, so it's likely that this happened, and this sort of explained the connection between the shoulder. But I think I have a few patients who had shoulder surgery, and not all of them have lesions of their nerves. It's actually quite a rare case. But we often have them, and the shoulder is quite okay, but then their hand has the swelling and the CRPS symptoms. And I'm always puzzled by this, but I still, if the Budapest criteria are fulfilled, I think this is it. But I don't know, maybe you have these cases as well. If there's a proximal injury and then the symptoms are distal and there's almost nothing distal other than the symptoms, I'm always a little bit surprised, especially if there's nothing like the elbow or the shoulder is completely fine, but the hand is the problem. Yeah. Yeah.
And we discussed, I think, that some of the description of shoulder hand syndrome are like that in the literature. So that seems to be something that does happen. And for us, and we need to have a better understanding what shoulder hand syndrome actually is, and get a better. But we also, like you, we sometimes in these situations and ask the surgeons, did anything happen? Sometimes with the positioning in the operation theater, something, they say, oh yeah, no, actually there was something else, and it's directly then a injury to the area, mild injury, and I then usually construe something and say, oh, well, maybe that's what caused it. But yeah. How about you, Janet? Do you see that sometimes this kind of a remote injury, seemingly usually to the limb, but then, distally you see, yeah?
Yes, we also see that, but as I mentioned, the other patient I also had, yes, you can see it. And sometimes I often have patients that develop pain after surgery on different parts of the body, not the ones related to the surgery. So I always thought maybe it's the initiation of some kind of healing or inflammatory process that is initiated by the surgery, because it's always associated with inflammatory processes that kind of trigger patients that are predisposed to something or have an underlying disease that is triggered by the surgery, for example.
Yeah,
I observe that in the clinic often, but there's no evidence for it so far, I think.
There's one question that I would like to answer. Actually, I don't know, and I thank you very much for raising this issue. So, is this related to interscalene block? That's a very good question. So, I don't think so, but I better check. Yeah. Okay. I think we're also approaching our final time. So
yes. Exactly. So thank you very much. I think there are no more questions at this point. Thank you, everyone, to the panelists for their wonderful presentations. It was really exciting to hear all this. And also to those participants who joined us today. Thank you very much. I hope this was for you also informative. And with that, we conclude the webinar. Thank you to EFIC for supporting us with that. Really grateful for that. Thank you. Take care. Have a good day.